Good morning, everyone. My name is Alex Castillo-Smith. I work at the Human Services Department with Secretary Scrase. And first of all, I want to apologize for the late start this morning. We are experiencing some technical difficulties with Zoom, and we're working to live stream to Facebook on the HSD homepage right now. But in the meantime, we'll conduct this press update with just you all and our guests today. I think with that, David, just for the essence of time, I'll turn it over to you so we can get started.
Thanks very much, Alex, and thank you for your patience and for attending. Again, we apologize. The link between Facebook and Zoom is sometimes temperamental, and particularly when we're all broadcasting from our own homes. But we're calling this briefing today to just go over and address some of the questions you all have asked as a result of the executive order that came out last week. We brought some experts today to go over crisis standards of care, what that means. Michael Richards, who's sort of a national expert on crisis standards of care, actually, and Vice Chancellor for Clinical Affairs at UNM Health System is with us today. Denise Gonzales, one of the medical directors of Presbyterian Healthcare Services, is with us today. She's been on a previous press conference. And so I'm just going to walk through with a very brief update of hospital capacity, and we'll get right to the topic of the day. The first thing to mention is there are 6 documents that you kind of have to put together to really understand what's happening with crisis standards of care, both nationally and in New Mexico. They're listed here. On the MAT website later today, we'll provide you with a link to all of them. Mike Richards is going to go through the first 3 in some detail. I'll make a few comments about the third one, and then the 4th and 5th. You've all read the executive order. There's a 6th document that may be coming soon, which is a public health order as well, which will round out the suite. And so today we want to walk you through these. All of these are available online. One of them is not a New Mexico document. It's a national document that Mike Richards will explain. And hopefully by the end of this webinar, you'll have a better understanding of how all these different pieces of this jigsaw puzzle just click together to form a unified approach in this really challenging time for our hospitals. You've seen this curve many times before. The green is the rising case count. There has been a leveling off and a little bit of a drop, but we're still at a level that is very challenging. The other thing is that usually hospitalizations, which are in the gray, follow cases by a couple of weeks. So we are expecting to see a little bit more of an increase. There's a lag in the data in our 7-day rolling average here. And you'll see in a minute that we're up well above 930 people in the hospital today. And then lastly, deaths, which is red and goes on this axis, whereas hospitalizations and cases go against this y-axis. Deaths at an all-time high consistently as well. And so 2 weeks from cases to hospitalizations, about 2 weeks from hospitalizations starting to go up here to deaths. And we expect then to see continuing upward trends in hospitalizations and deaths, at least for a little bit. If this holds, this downward trend, then we'll start to see those two coming down as well. Hospitalizations today, we're at, I think it's 1,007 altogether. These are people in the hospital with COVID or likely COVID waiting a laboratory test. Obviously an all-time high, as you can see from the beginning of the pandemic. And actually this takes us way back to just August 5th. But even if you go way back, obviously, we haven't had this many hospitalizations. And as of this morning, or yesterday morning, excuse me, you can see some open beds, about 23 ICU beds available throughout the whole state. But do pay attention to the 0s and 1s and 2s in most rural areas of the state. The vast majority were in Albuquerque here. And the same with medical surgical beds, very, very tight throughout the state. And sometimes these numbers like 7 or other ones actually maybe overrepresent where we're at, because I know on Friday we had 20 or 30 open beds at 6 in the morning. And by 3 o'clock in the afternoon and our meeting with the governor, those were all full. So it's a very dynamic situation that changes by the hour. And you're going to hear how we're managing that when we get to Dr. Gonzales. But first, Dr. Richards is going to explain to you all how he thinks about crisis standards of care and what that construct means. And I think you'll find it as helpful as I did when he explained it to me back in March of this year. Dr. Richards.
So thank you very much, Secretary Scrase, and I appreciate the opportunity to present some of the materials regarding the crisis standards of care. And I think that starting with some background material may be the best way to set the stage for this. And it's that the crisis standards of care document, as you've kind of pointed out, is connected to some other key documents. Two documents going up, and these are kind of general documents, and those are the state all hazards plan, and there's one for the state of New Mexico, and then there's a Department of Health medical specific all hazards plan. And so the crisis standards of care document is connected to those. It's not a standalone. And then I'll talk in a couple of minutes about how it connects to some event specific documents related to COVID. But before we do that, I think it's important to kind of talk about where the concept of crisis standards of care came from. And it really came from the understanding that nationally, our experience with influenza, originally with H1N1 and about the late 2000s, was that we could in fact find ourselves as a nation in an event where a public health emergency or disaster where resources would not necessarily be able to manage the demand on a large scale. And if we were to have to make those kinds of decisions about how we would use those resources in a time of scarcity, what really would be the framework for how we would make those decisions? And it really was driven from the concept of pandemic influenza, which is not unlike the kind of event that we're in now. And so Health and Human Services asked the Institute of Medicine to convene a national work group, and the product of that was the concept of the crisis standards of care. Now, we use that in New Mexico as the basis for our establishment of the crisis standards of care, but I want to visit one term in particular, and that's the word crisis in this, and that, you know, that term is really intended to represent a state, a condition where resources and demand become mismatched. It's not necessarily intended to represent a mindset, because while the delivery system may find itself under significant stress, the healthcare professionals that build and run our delivery systems do this in a very level-headed, thoughtful manner that doesn't really represent a state of crisis in their kinds of actions and behaviors. And so I think that's an important distinction to make. So our crisis standards of care document for New Mexico, which was promulgated in 2018, set this framework, and it's based upon this national construct. And it did involve establishing some things such as the medical advisory team concept, which you've heard about, and it really focused on addressing the ethical issues of how we would use resources in a time of scarcity. So when demand exceeds capacity. Once we were headed towards the potential of a COVID pandemic, and this would have been in January and February of this year, the healthcare delivery system started meeting with the Department of Health to start doing some event-specific planning for COVID, and that resulted in the development of the New Mexico Statewide Acute Medical Surge Plan, which is specific for New Mexico and specific for the COVID pandemic event. And I'll talk a little bit about that. And it linked that response of our statewide Department of Health and the medical delivery system to the concepts of the crisis standards of care. And so it includes how we would make those kinds of ethical decisions if we came to that point in our statewide response. Next slide. It's important to talk a little bit about the medical advisory team, because one of the key concepts in the crisis standards of care in our acute surge plan is that the state leadership really connected to the delivery system leaders to participate in the development of these plans and these documents. And so that involved the establishment of this medical advisory team, which at one point had over 140 health and emergency response professionals from New Mexico participating on developing this response plan. That group had a chair that reported up to a DOH leadership team that included Secretary Scrase and a daily operations group, but it was also broken up into multiple work groups of subject matter experts. And we've listed 7 of these work groups that include things such as regional response planning, clinical care, and an example of the kinds of things that the clinical care work group would focus on. That team of medical experts led by physicians who have expertise in this area, we're looking at things like how you would use ventilators to manage COVID patients, how you would use adjunct therapies for patients requiring respiratory support in an ICU, how drugs and therapies would be used, how to best use and conserve personal protective equipment or PPE. And so that would be an example of the kinds of things that that group would do. So even though there's 7 here, almost all of these had work groups, subgroups of 2 to 3 or 4 that worked on specific questions. So about 140 so individuals in there. There was also a group of legal and ethical experts that we worked closely with that reported directly to the DOH leadership team. And I'll talk a little bit about some of their work. In addition to those subject matter experts and work groups, there was also a hospital and health system advisory group that was largely representative of the hub hospitals and the New Mexico Hospital Association and the professional societies. And I'll talk a little bit about who they were in just a couple of minutes. So this concept of putting together the crisis standards of care, the concepts that we're going to talk about in a few minutes, were all collectively developed by the medical and governmental leadership in a very collaborative way in our state. So next slide. So I want to talk about some key concepts of operations that are both in the crisis standards of care, but also in our acute medical surge plan for COVID-19. And so the most important one is that as we start to look at the spectrum of response, what happens in a large scale event, in this case COVID, but in any kind of large scale response, we move from conventional care, which is the way that we would deliver health and medical care, in a normal circumstance where resources typically are greater than the demand. When we move from that state to a state where the demand starts to increase, when we know that the demand for services are going to start to increase, we can then move into this phase, which we call contingency care. And what happens in contingency care is that we start to create new systems of care, which largely are equivalent to what we would do in conventional care, but they're oftentimes done in either different locations, like different parts of the hospital, or sometimes with different equipment, or in ways that we would use the equipment and material differently, such as conserving or augmenting the materials and supplies. But the real intent during the contingency care phase is to ensure that we're adding resources to keep up with the demand. And during this phase, there's essentially a lot of equivalency that happens with the levels of care that ultimately we're able to produce. And because of the prolonged nature of the COVID response, our state has actually been able to build a significant amount of contingency care. And we'll talk a little bit about that. And Dr. Gonzales will give some very specific examples about how we move into this new level of care. The indicator or the trigger for moving from conventional care into contingency care really in our case was the declaration of the public health emergency. But as we continue to see the demands on the delivery system go up, at some point, the demands start to really put significant pressure on the available resources. And potentially, the demand can exceed the available resources. When that occurs, we're in this state of crisis care, which, like I said, is a label that, isn't necessarily reflective of the atmosphere. It's a state of whether the resources are matching the demand. And as we move further down the spectrum towards this crisis care definition, we continue to build all of the contingency capacity we can. And in fact, we never step away from using those approaches to adapt, conserve, and augment to try and provide as much equivalent care as possible. However, at some point, you can get to the place where the demand does exceed the resources, and you have to then start to make decisions about the care that would be provided, allocating the care and potentially providing triage to care. And the crisis standards of care framework really sets up the guidelines for how you will ethically make those decisions if you have to start the triage, and to put together protocols. The trigger for when that happens is actually when the resources don't match the demand. And in some cases, this, in some cases, this can happen really early in an event. In our case, we've had months of this with months to prepare, and we're not there yet. But in terms of having to make triage decisions, but we actually are at a place where the clinical delivery system has enough pressure on it that we technically need to be prepared to actually have those systems ready to go and to be implemented. Another important consideration on this spectrum is that as you move from conventional care to crisis care, the delivery system has to start to shift its priority and its focus from being able to say that in conventional care, the primary responsibility is to the individual. So the healthcare provider that's delivering the care has this duty to the individual. But as the resources become scarce and we get really further along down the spectrum, then the focus shifts from not just being concerned about the individual, but making sure that we're making decisions that maximize the good for all of the patients, not just the individual patient. And so that's a concept that's built into the crisis standards of care. Next slide, please. So some other important considerations are that very early on in this event, January, February, and in March, the delivery system, as it was meeting with the Department of Health leadership, collectively made the decision that we would have a well-coordinated statewide medical response. And now, not all states have been in a position to bring together the delivery system with the state leadership in this kind of, highly collaborative partnership. And so this is one of the things that we believe has allowed us to have, the response that we've had so far to this event, in that we've said, we as New Mexicans really have to pool all of our resources and our talents, and to think about all of our resources as a state rather than as individual institutions and individual providers, to be able to ensure that we have the maximal response. And this ties back, Secretary Scrase, to that slide that you showed at the very beginning, where we have some hospitals who may not have any capacity and other hospitals that have some capacity. And so part of what we wanted to do was to collectively work on how we could build as much contingency capacity by sharing information, sharing tools, working collaboratively on those processes, but then also putting together a statewide response model that we call the hub and spoke model, that says that all of the hospitals will work together as a coordinated network under a concept of regional surge planning, so that if we did have one area of the state that was impacted more than others, that the delivery system would be well prepared to move patients to those areas where there would be capacity. And so that involved hospitals, which were larger regional referral centers, building connections and networks with their hospitals in their referral areas. And Dr. Gonzales will be able to, in a few minutes, to talk about some very specific examples of what that means on a day-to-day basis for building hospital capacity. But the other really big important concept that I believe New Mexico may have been one of the first states to adopt this idea was that we would also put together a centralized call center under the direction and the auspices of the Department of Health, where the clinical delivery system would come together and implement the ability to have one place where calls could be routed so that we would have an understanding of where capacity would be in the delivery system so that we could then route patients to hospitals that would have the ability to be able to take care of them. And that is a very different approach than the way that we would do it under normal conventional care. Another important aspect of having a centralized call center would be that we could then staff it with medical triage officers who could then, under crisis standards of care protocols, help make decisions with the local hospitals who were sending patients about ensuring that patients were going to the right hospital at the right time. And that's all built around the crisis standard of care framework. Another important component of this was also being able to work to stand up alternative care sites and alternative ways of delivering care. And as we get into some of the specifics, you'll hear about what that looks like as we're now several months into a COVID response. And so with that, Secretary Scrase, I'll hand it back to you.
Thanks. So I just wanted to go and talk a little bit about that. The metrics Mike mentioned to move from one section to another or one level of care to another one. We kind of divided up contingency level into two parts just to sort of track progress. But the governor's office, I think, wisely asked us to come up with as objective as possible a method for scoring where we were at, so we would know when we got to crisis standards of care. And also just, I want to mention that at any given point of time, there will be beds open in some hospitals around the state. And so what Dr. Richards mentioned about pulling everyone together as one system really does allow us to leverage the fact we have a much lower number of hospital beds per 1,000 people in our state than most states do. I think we're in the bottom 6 in America, and also a lower number of providers. So the hospital, the hub and spoke team really scores this grid every week. And what you're seeing here is the graph of that. You can see we started just before Thanksgiving, scored it. We're aiming to score it once a week, although we did an extra one because we suspected we were getting into crisis standards of care in early December, confirmed that, and the MAT wrote a letter to DOH saying we think it's time to declare crisis standards of care. That's the 6th document that isn't out yet, but is being worked on to sort of announce that change, and as is described in the executive order. Today, again, a little bit more into that range. The complete score sheet is available online. This is kind of a summary, and on the one you'll see online, there's words that describe the situation in every one of these, and you can look at what the descriptions are. And then this is a rating that's was done this morning, actually, this morning by the team. So you can see crisis standard of care. If it's all red, it's 3 points for that particular criteria. If it's only contingency level 2, then it's 2 points. And if it's only contingency level 1, then it's 1 point. But as you can see, if you do the math, this is how we get that aggregate score that's translated into this 35.5 here. So we do that weekly. We believe now that the level of pressure is high enough that we're ready to move into the crisis standards of care designation. And Secretary of Health, Acting Secretary of Health, Billy Jimenez is working on that now. I'm going to turn over to Denise Gonzales to paint you a picture of how this actually works on a day-to-day basis, who's involved, how local communities and regional communities and hospitals are involved, in trying to make as much room as we possibly can in crisis standards of care to take care of as many people as we can to avoid actually having to ration care. So with that, Dr. Gonzales, I'll turn it to you.
Thank you very much, Secretary Scrase. I wanted to thank you for the opportunity to represent what we're calling the delivery system, and that's all of the hospitals and hospital systems throughout the state. After the first wave, hospital operations in New Mexico began to prepare for what we suspected would be a second, possibly third wave. We worked to contract with traveler nurses and traveling respiratory therapists. We prepared rosters of our staff from our clinics and other areas who could redeploy to hospital care. And we've worked to expand the scope of practice. For example, having pediatricians trained up and ready to take care of adults, or using team-based care in order to augment and to extend our nurses. Next slide. We've increased our spaces to care for New Mexicans in very many ways. We've increased overall room capacity, sometimes by putting more than one patient in a room. We're also being innovative, because it shouldn't just be about how do we do our conventional hospital care in more spaces, but how can we prevent patients from even needing to go into the hospital? For example, we've been identifying patients who are well enough to be safely treated at home and administering remdesivir, the antiviral drug that treats COVID, to them in an outpatient infusion center that helps to prevent hospitalization overall. And then lastly, finding patients who are positive for COVID who have risk factors and giving them advanced treatments such as monoclonal antibody cocktails before they even become sick, again, to prevent hospitalization. It's another innovative way of improving our healthcare capacity to treat patients. Next. We've had an exceptional amount of collaboration between the state and the delivery system. And I think it's unique across the country that we have this degree of collaboration. I want to thank Dr. Richards for helping to develop this system. Currently in the hub and spoke model, individual hubs are meeting with their spoke hospitals on a daily basis to get a sense of where they are with capacity and whether they have any resource needs that they can then escalate. Also daily, we meet amongst the hub hospitals with representatives in order to go over our load leveling plan. You see there on the right an excerpt from a tool that we use to ensure that we're balancing admissions across the state, actively pulling patients out of hubs that are excessively full, and sending patients to health systems that can absorb that volume and take care of patients. Then the medical advisory team also calls in with the regional hubs twice a week, likewise to escalate issues. Again, it's a very collaborative system where we're all working together so that we can maximize care for all of New Mexico and not have any resource shortages. So for example, last week, there was a hospital that escalated that they had to use 2 of the beds that they label as crisis beds, meaning that it's beyond what's in their contingency response. And we didn't want any one hospital to go into a crisis standard. And so we actively pulled together and pulled those 2 patients out of that hospital in order to load balance. Again, with the focus being on not restricting care, not rationing care, but rather how can we all work together so that we can maximize the healthcare that we're able to deliver to New Mexico. This week, a new escalation came across. There's a hub system that is short on ventilators, and we were able to call across the system, asked a couple of hubs, and they were able to procure some ventilators, and the state helped us to transport ventilators to that hub hospital. Again, a great source of collaboration. And then the last thing I wanted to touch on is that the the State Transfer Center, under the auspices of the Department of Health, also has a group of medical directors, physicians who can help via consultancy with those hub hospitals to determine how do you make up your triage teams? How do you perform triage? Help to support them in making difficult decisions if and when they have to be made. Next slide. I do want to close with saying that our community is our greatest ally. People are stepping up, including retirees that you may have seen announced recently. Everyone wants to help in our response to this pandemic. We're fortunate to have such great collaboration that's unique to our state. But still, we do need everyone's help. Please, if you can, stay home, limit gatherings, use your mask appropriately, consistently, and as often as possible. Keep your hands clean. And with this, we all can be heroes.
Thank you very much, Dr. Gonzales. And I just want to close with a couple other things that, something that's happening right now and something that's going to be important in the future. The licensure boards in the state are actively considering ways to also provide support to doctors and clinical nurse clinical nurse practitioners, pharmacists, and the New Mexico Medical Board has approved a resolution, basically also reassuring providers, saying basically, we know that you may be stretched outside the normal scope of your practice. We understand this is necessary because of the situation that we're in as we move into crisis standards of care, and that we have your back on that. And so, I mean, this I think is reassuring to physicians who are in an outpatient setting who now will be called up to serve in a hospital setting, to pediatricians who will be taking care of adults for the first time in a really, really long time, or to anesthesiologists who are going to be moving into intensive care units to provide care. And so you'll be hearing more about that in the weeks to come. The other three boards mentioned here are busy at work and convening special meetings to discuss these levels of support as well. And then lastly, the one document that we didn't talk about that's been on the MAT website homepage for probably 8 months now is the triage protocol. And I'd encourage you to take a look at this. It really talks about what do we do when we have more resources, when we have more people needing critical resources than we have those resources, and we can't get them from anywhere else. When we've expanded as much as we can expand, when we've converted operating rooms into ICU beds, when we've converted outpatient care settings into inpatient care settings, when we're taking care of as many people as we can in hallways in our facilities. And all of those things are now currently happening here in New Mexico. And so it talks about the ethical considerations. It talks about the establishment of local triage boards. You know, the government really isn't making any decisions about critical use of resources. That will be all set up and run in local triage boards. Dr. Richards and Dr. Gonzales described that hub and spoke system by which we can provide support to those smaller rural hospitals and from the hub hospitals and from the state to the hub hospitals. But all of that decision-making happens at a local level. And then lastly, it talks about what sort of information would be used to make triage decisions. And usually in a situation like this, particularly as we get more into it, rumors abound. And really, if you read this document, there's a 1.5-page preamble that's a great summary, or you can read the rest of the pages if you like. But really, the ethical team said really the only criteria is one's ability to survive the infection. And that's the only thing that should be used to determine resource allocation. So I'll leave that to your reading, but this guide is present. These triage boards are now up and running in almost every hospital, certainly in all the hub hospitals. They're working with the spoke hospitals to get them up and running so that in the next week or two, as these decisions, if they do come to need to be made, we'll have the structure and the process in the local communities with local physicians, local hospital staff, and other providers making these triage decisions in the best possible way. And that's really the end of the overview. And we want to open it up and allow you an opportunity now to ask questions. I think Alex is going to moderate that for us. And so I see a hand raised, Alex, but you may have other people on the list already.
Yeah, we've got several hands raised, and I'll try to go in order of appearance. So we'll start with Julia Goldberg and then go to Brittany Bade. Julia Goldberg is with the Santa Fe, New Mexican. So Julia, you should be able to ask your question.
Thank you. I'm actually with the Santa Fe Reporter. I have a few questions, and thank you for this opportunity and all the information. Yesterday in the news briefing with Lovelace and Presbyterian and UNM, the doctors said that crisis care, that there's no magic number and that could change hour to hour, day to day, and patient to patient. When the state allows for crisis care and then it is perhaps implemented at different facilities, what level of transparency is there for the public if specific facilities are in that situation? And then my second question is, I was wondering if perhaps one of you could actually maybe provide an example of a triage situation and the ethical considerations, just so that I had that in my mind of what we were talking about. And I have 10 more questions, but I will leave it at that. Thank you.
Yeah, I'm gonna actually ask Denise and Michael, Doctors Gonzales and Richards, to address this. I think our goal is to have as much transparency as we can. I think, like Dr. Richards, I think of crisis as this state that the entire state of New Mexico is in, and not one hospital on one day and one hospital off the next day and on the next day and off the next day. Because remember, in crisis care, there's still that opportunity to expand even more than we are already. But let's start with Dr. Gonzales in terms of your thoughts on maybe an example of a triage situation and what hospitals have been talking about in terms of transparency.
Yes, Secretary Scrase, I think that it's a wise question to go through this by using an example. And I've done this a couple of times in training some of the hub and spoke hospitals on how to implement the tool. First, I want to say that as a physician, I appreciate the fact that the tool is very objective. It does everything possible so that we can be fair and equitable across the spectrum of patients that might present to us. So one of the examples that I use is a situation where every hospital ICU bed is full and a patient presents to a small outlying hospital. They have chronic kidney disease, they're on dialysis. They have a cancer that doesn't have very great survivability, and they have COVID and are needing a great amount of oxygen. One half of the tool that we use when performing triage is to consider chronic diseases, and the other half of the tool is the acute problem, the presenting issue in this moment, things like blood pressure and oxygen needs. So when you score a patient like this example, they end out having a score that lands in the orange level. That's the in-between level. It's not the highest priority patient who has a very high likelihood of surviving. It's also not the most terrible patient who has no likelihood of surviving. But this hospital doesn't have a bed available for them. So then the next step is to contact the regional hub hospital to present this patient, and then the scoring is adjudicated so that you compare everybody who's already in a resource that's needed to this patient who's trying to gain entry. And if that bed is available for that patient, then they're able to be transferred up to that regional hospital. And then it just gets escalated depending on what the situation is. But the tool itself is as free from bias as it possibly can be.
Mike, Dr. Richards, do you have anything to add to that from your
Yeah,
perspective?
well, I think that Dr. Gonzales has done a really good job of describing that. And so when we talk about the tools, just a couple of points to add is that they're objective tools, they're applied by medical professionals, and what the crisis standards of care does for us is it allows us as an entire state, a delivery system, to agree on what those tools are, so that they're going to be the same tools, across the state. So that when a receiving hospital is talking with their potential transferring hospital, the hub and spoke, that they'll be using the same methodology and the same tools so that we can all be as consistent as possible. The other really important point for us is that as we came together to decide how we would use these tools in New Mexico, we really landed on the concept of fairness as being the most important driving principle. So this gets back to the questions about transparency. And I really encourage folks to read the document to see how the concept of fairness is played out. And so as you pointed out, Secretary Scrase, this is the decision about if we have to choose who would get a particular resource, it's based upon their likelihood of benefiting from the resource. And so so there's a very intentional statement in there that we will not make resource allocations based upon gender, race, ethnicity, religion, social status. Age is not a determining factor, or in some places you may see that there's a concept of societal value, like this worker is potentially more essential than the other. We don't have that in ours. We really have kept it to the concept of fairness. And so with the idea that that's the most transparent way that we could apply this. The other really important point I want to make about this, and this gets to the concepts that we just heard about, well, it may change from day to day. And I know that may be a little bit confusing, but there's no one bright line that we cross that then says we'll do this for every patient in every circumstance. And what I mean by that is that, we won't start making decisions. The healthcare professionals won't make decisions about allocation of resources until it's necessary. So, we will continue to build as much contingency capacity, use as much alternative ways of delivering the care as possible, and only apply this as needed. And this gives us the tools for agreeing on how we would do that if we get to that place, which means that care will still be provided to all New Mexicans. It's whether or not certain therapies, if we have to choose because of scarcity where they would go, how we would make that choice.
Yeah, and really, I'll just close by adding one last thing. Like, I think the goal of this statewide system is to not be in a situation where there are 20 people in Las Cruces who need ventilators and 20 spare ventilators in Farmington. And so Las Cruces is in crisis standards of care and Farmington is not. Our job is to level load those resources across the entire state. The state won't have a public facing tracking system for who's in which situation. I think each hospital is going to have to figure out how they're going to approach transparency as far as their own systems. But I don't think it's the sort of situation where, if we're doing our jobs, all of the resources will be fully allocated, and then almost every hospital will be in that allocation, having to triage decisions at the same time.
Yeah, I have to agree. I suspect that that's what the physicians yesterday were trying to express, that it'll be a different situation every day, but the tools and the transparency will be consistent throughout.
Okay, next question, Alex.
Yeah, thank you, everyone. Next, we're going to turn to Brittany Bade with KRQE. Brittany, go ahead.
Hello, everyone. Thank you very much for your time. Looking at, obviously, hospital capacity, the point we're at now is clearly a crisis, critical level. People have been critical of the restrictions that New Mexico has been under. If we were to look at what would happen if people hadn't been wearing masks, there were no closures, there were none of these mitigation efforts, and this is speculative, but what do you think the statewide death toll or the situation in the hospitals we would be in now if none of those measures had been in place to try and contain this virus at all? My second question is in regards to the vaccine. We know that we're getting, 17,550 doses. Those have been ordered. Do we think we got our fair share there in regards to the 6.4 million doses available nationally? And if that vaccine, the Pfizer vaccine, is approved this month, how long realistically do we think it'll be for everyone in New Mexico who wants one can get one? Those are my questions.
Great. Well, let me just take a crack at some of them. The trouble with talking about vaccines is we have vaccine projections, and then we have vaccines that we actually have right here in the state right now. The latter number is 0, and the projections change pretty frequently. And so I think on that one, I haven't seen anything that would indicate that there's an unfair allocation of vaccine. And I think you're comparing the 17,500 is not actually directly comparable to the 15 million nationally, because I don't think that is the initial delivery. And then what if, I'll just say something about what if no containment. I don't know what would have happened if nothing had been done to try to contain the virus, but I'm pretty sure we would have been having this press conference last summer and talking about those issues then. I mean, we were on a fairly steep upward curve then. I think the mitigation certainly reduced the death rates. And I can't give you an exact number of projected deaths we'd have now because, the public does react to the severity of the pandemic in the state at a given period of time. And with or without public health orders, which I think are important, the public still will, retreat to sheltering in place if they perceive their community or the situation to be quite dangerous. So that's something to think about there. And in terms of timing of when we'll all be vaccinated again, I have a number in my head where I think that maybe 60 or 70% of our population will end up being vaccinated, but I think it's toward the end of the summer, not April or May. And we will know, the only way we can tell you the actual answer to that question every week is by the number of vaccines we actually have present in the state that are going into people's arms, while each day they come in. So I wish I could project more. We have teams at DOH working extremely hard on this and setting up entire systems. We have providers being registered, but there's just no way to say how long it's going to take or how many vaccines we're going to get until they're actually here. Anything to add about the what if there was no containment part? Okay, I'm not seeing anyone raise their hand. So Alex, next question.
Thanks, David. Next, I'm going to go to Robert Knott with the Santa Fe New Mexican, followed by Tessa Mentes with KOB4. Robert, go ahead.
Thank you, Alex, and thank you, Dr. Scrase. Thank you, all your doctors. We do appreciate this. I want to follow on the triage question because I liked Dr. Gonzales, Dr. Richards explaining it that it would be to the benefit of one patient perhaps over the other. But I'm going to put it in those stark layman terms without hopefully creating myths and rumors. If Mr. Smith has cancer, he's really having a hard time making it. It doesn't look like he's going to make it. Could resources for him be allocated to Mrs. Smith, who has a chance? I don't know how else to ask it, but I think it's a fair question. My second question is, how soon could this happen? Because you're all sort of hinting that it's right around the corner. Are we talking within a week this could happen, within 2 days, maybe end of the month? Thank you again. I know these are not easy questions to answer.
Yeah, I think we're at the point we're at, and these are great questions. And that's kind of why we're having the press conference, is because everybody's asking these questions, and we haven't had a chance to answer them before. And like all the other things that these press conferences do, they raise angles on this that get us thinking and going back to deliberate further. I think that I'm going to let Drs. Richards and Gonzales talk about the two patients you described and how that might work. I think in terms of timing, we're here today because we think it could be very soon. We're here today because we're well over hundreds of patients over the normal capacity in most of our large hospitals, completely full ICUs. So we're thinking this month. Matt made that recommendation last week to DOH because we felt like we were on the threshold of this situation. If cases level off and hospitalizations level off and come down, we'll have another reprieve. But the trajectory last week, and frankly, this week in some of our big hospitals, suggests this could be something that we absolutely have to deal with between now and the end of the year. With that, I'm going to kind of turn it over. We haven't really gone into detail about the SOFA score tool, and it probably is just as well that we're not going into a lot of detail about that, but maybe one of you or both could talk a little bit more about this objective scoring system and how we consider Mr. and Mrs. Smith, and who it, for the purpose of this question, just to make it a little easier, we'll just assume aren't related to each other.
I'll start, Secretary Scrase, and because I'd like to actually make a couple of comments about doctors like Dr. Gonzales, who do some level of this every day in their professional life. And that's something I don't want us to lose sight of. So the question really was, was a very specific triage question, one patient over another. Now, the one key point about this is that all patients will get care. And really the triage decision is about a specific therapeutic intervention. If we were at a place where we had to make a choice about a therapy being given because there wasn't enough for both patients to have that, so how would that be made? And you mentioned, Secretary Scrase, that there's a scoring system that's used, and there are two parts to the scoring system. And the first one is the SOFA score, which looks at biological measures that are predictors of how someone is likely to respond to, a potential intervention, the likelihood that they would benefit from it. And then the second part is major comorbidities, and so the cancer one would be considered a major morbidity. And so those scoring mechanisms allow you to say which of these two patients would be the one that would most likely benefit from a particular therapy. That's done by physicians at the bedside, using this biological criteria that we've all agreed upon. And again, it's based upon the fairness, who's likely to benefit from it the most. And the reason why I wanted to start is because, like I said, Dr. Gonzales is a critical care physician and works with families and patients, every day, helping make decisions about when therapeutics are really to the benefit of the patient, and helping families make tough decisions. And so this is work that many healthcare professionals are quite familiar with. What's different about this is that we've all come together to agree that in this event, this is the set of tools that we will use if we have to make these kinds of decisions. And Dr. Gonzales?
Yeah, thanks, Dr. Richards, for pointing that out. It is true. I worked last night, same conversation, every patient and their family every day, talking about this is how ill you are, this is the likelihood that this intervention might work, might not work. So we are carrying out those conversations every day. The particular situation that you posed to us, I think it's important still to go back to the fact that if the resource is available and it makes sense to apply that resource to that patient, then it'll be offered. So just because some declaration gets made doesn't mean all of a sudden Dr. Gonzales is going to say no to everyone. I'll still do an assessment. I'll still have a discussion with family members. And then if there is a scarcity of a resource that is a consideration for application to a patient, then we're able to have that discussion. And if I'm trying to transfer a patient to another hospital, that scoring tool helps to communicate the urgency of the need for my patient in comparison to the patients who are already in another facility.
Okay, Alex, next question.
Yeah, thank you, everyone. Next, I'll turn it over to Tessa Mentis with KOB 4. Tessa, go ahead.
Thank you, Alex, and hello, Secretary Scrase and Doctors Richards and Gonzales. Thank you so much for taking some time to answer these questions. We appreciate it. First question is based off of something that I get asked multiple times a day every time we talk about hospital capacity. And that is, do we currently have any out-of-state patients in our hospitals? Conversely, are there any discussions being made as to whether or not we could work with other states if we would need to transfer New Mexicans to get that care? I know that really there's no surplus of space nationally, but in that twofold question, I wanted to present that to you. Secondly, this is kind of a two-part second question. I think a lot of times folks see those daily updates that we give out to viewers every day. Yesterday we had 1,800 cases. How can you address kind of the amount of attention or leverage we give to those updates when balancing out the need for everybody to do all we can do? In other words, we don't want to see a day, maybe hopefully, where we have 700 cases and think, wow, we've really turned the corner here. So what is the main criteria, Dr. Scrase, Dr. Gonzales, Dr. Richards, that you would want folks to really focus on? Is it listening to you? Is it those daily updates? I know I threw a lot out at you, and I apologize, but also thank you in advance for tackling everything. Thank you guys so much.
All right, I'm going to think that the great questions, Tessa. I'm going to go to the in-state, out-of-state issue. We've showed slides on this in the past. Every time we look at it, the number of New Mexicans in out-of-state hospitals compared to the number of out-of-state people in New Mexico hospitals is almost always equal. We are still transferring people to Texas and Arizona and to Colorado on a daily basis. I think there were, and I wish I could have brought the slide up quickly, but there were about 20 to 30 such people over the weekend that got transferred out of state. So there isn't a net, we're not a net importer or exporter of people, with other states with respect to our hospitals. We looked at this 3 or 4 times. Usually a reporter asks, then we run the report again. There is a report online on DOH under the epidemiology section that has hospital reports, and they do talk about that and show that graphically so you can just track it. But it tends to almost always be just exactly equal. In terms of what should people really pay attention to when it comes to the pandemic, I'm going to start. I'm going to turn it over to my colleagues here as well. But I think they should pay the most attention to the word pandemic and the fact that, and maybe individual responsibility that we all have in a pandemic. In this crisis standards of care, we're talking about a slight lessening of a physician's obligations to take care of an individual patient and an increase in the obligation to the entire community. And I think we all have that exact same obligation to our entire communities, ourselves right now. So I too worry that, 700 cases, we'll be in like triple digit numbers and think that's the best thing that ever happened to us, when the fact is we haven't had these 4-digit number of daily cases except for just in the past month. We have like 20% of our deaths in the past 2 weeks, 30% of our cases in the past 2 to 3 weeks. And so I think it's paying attention to keeping yourself safe, keeping your family safe, keeping your community safe. And as long as the virus is out there, it's willing to infect anybody who leaves themselves open to being infected, wants to spread from person to person. And so I would just stay focused on the fact that we're in a pandemic. Once we're all vaccinated, or 60 or 70% of us have immunity, it'll be a different world. But till then, I don't think the case count is critical. This conference today is all about hospitalizations and our overfull hospitals. But at the end of the day, until we're all vaccinated, the virus is going to be just as infectious as it was on the first day, and in the peak in late April, and the peak in July, and the peak we're having now. Let me ask my colleagues if they'd like to add something onto that. Dr. Richards.
So Secretary Scrase, I agree. There's not a magic number. We're in a pandemic, and as long as we're in a pandemic, then we're at risk. And so if it's, it's not that we can have 700 cases a day and then let our guard down, or say at 250 we let our guard down. We can't do that at any one point, because as we've seen, the disease can spread so rapidly that we can get to doubling times, which then put huge pressures on our delivery system and healthcare delivery system. And it's not just about COVID. It's about, having healthcare and access to healthcare for everyone for all kinds of medical conditions. And so, having a delivery system that has, an extra 1,000 COVID patients in it, impacts everyone, because then it's more difficult to take care of individuals who might be in a car accident, or who might have a heart attack, or who need to get surgery so that they can walk safely, to get a knee replacement. And so it impacts everyone. And so I think that the most important thing I think that folks can do is just recognize that for right now, it's our individual behaviors that matter the most. It's whether or not you're practicing, COVID safe practices that help prevent the spread of the disease, and that it's not the public health orders. It's, the public health orders help frame what we need to be doing as individuals to ensure that we're protecting each other, and that we've got a healthcare delivery system that has the capacity to take care of not just COVID patients, but all of our medical needs in the community.
Yeah, I think I said it a while ago, but a couple weeks ago, but it isn't the public health orders that decrease the number of cases. It's us all following the public health orders that decreases the number of cases. Okay, next question, Alex.
Yeah, thanks everyone. We've got 4 more folks that have questions. And so first we're gonna go to Algernon Damasev with Las Cruces Sun News, followed by Jeffrey Plant with the Silver City Daily Press. Algernon, go ahead.
Thank you, and thank you, doctors, very much. I'm, of course, reporting from down in the southern part of the state. And so this is a different hub and spoke in the statewide system. And I want to get this right, because I don't want to create unnecessary fear in the community where I report. Dr. Scrase, I think earlier in this presentation, you said that your data shows 23 ICU beds available statewide. I get reports from our local Joint Information Center, which reports data from the 9 southwestern counties. And as of noon yesterday, they're saying 68 ICU beds are available, which is a very different figure. I don't know if those are all conventionally licensed ICU beds or not, but I'm trying to assess basically whether there's differentiated proximity to crisis standards of care, and also if there's capacity in this part of the system. Is it an option to sort of load level some of those patients down here? Do we have facilities that just can't provide higher level care, and so it's not as helpful? I'm trying to reconcile the picture here to explain to my region what this really means for us.
Yeah, and that's a great question. And there are a lot of numbers floating around. And so I think it's good to clarify that. And I appreciate you asking that. You know, we've got, so capacity is the number of beds you think you have, you know, that you can cover minus the number of people you have in those beds. So if you got 120 beds total and 100 people are in them, your capacity is 20. So let me walk through 3 or 4 reasons why we struggle to add these numbers up and why you are likewise struggling. Number one is that our system for reporting doesn't take negative numbers. So if UNM hospital has 140 more people in it than they have normal bed space, and they had 1 open bed, that would go in as 1 open bed into the system. So that's part of it. Second thing is hospitals are reporting beds that could be used for COVID patients and then ones for non-COVID patients. So for example, normally a hospital with 2 open beds on a maternity ward wouldn't report those as beds that were available for COVID patients. Now, if we get to, you know, sort of a statewide complete crisis standards of care, then we're going to have to make some decisions about how to handle even that eventuality. And we spent a lot of time on this in November. There's even on the website and in the gating criteria, we've got sort of this contingency number of ICU beds at 439, but it turns out we can't staff all those. We don't have enough nurses to really fill up that many. And so we're working across the entire state to have this reporting be identical, but your basic point is exactly correct. If the last 4 ICU beds in the state are in Las Cruces, and we've got a person in Farmington, Gallup, Albuquerque, and Roswell that need one of those last 4 ICU beds, part of our job is to move those people there. And so there will be more driving, and there's discussions about how do we do that? Should we meet halfway? Do we take the person all the way there? Because that ties up a rig from a very small community potentially for 10 or 12 hours that it needs to be in service in the community. So we're working out those details, but I can see why you think it's confusing. The key number though really is the fact that we have over 1,000 people in hospital beds in the state. I heard this morning on our report that one of our systems has over 50% of patients COVID positive in one of their hospitals. A number of our ICUs have 100% of the ICU patients have COVID, or 100% of ICU patients are on ventilators, which is very unusual for an intensive care unit. And so the math can be daunting, but there are some beds that just hospitals don't feel comfortable moving COVID patients into. If you had an oncology ward, for example, where everyone has their immunity suppressed in a hospital, that would be a very, very poor choice for a COVID patient, despite the ability of a nurse and a doctor to, wash up and clean up between patients. I'm going to go to Dr. Gonzales, who'll be able to tell you more practical details.
I just wanted to clarify that when we set up the hub and spoke system, it's for the entire state. And so we've been carrying out routine phone calls with leadership at Memorial and Mountain View. We've discussed what their hospital capacities are, what their plans are for transferring in from their spoke hospitals, and how they've been working very closely, in fact, with the Southeast Hub as well, which has been a great sign of their collaboration. When we find ourselves in a situation where we can't place a patient in a regional hub, for example, in the Northwest, then we look to take the call into central New Mexico, but that doesn't mean that the patient is going to be placed in central New Mexico. It means that we will look across all of the regional hubs and find the hospital that has the capability, and the patient will be transported to that location, because we don't want to limit care just based on where the patient originates geographically.
Right.
Thank you, everyone. Next, I'm going to go to Jeffrey Plant with the Silver City Daily Press. Jeffrey, go ahead.
Hi, thanks for the webinar. This is great information. I wanted to ask about financial stresses on hospitals. right now, elective surgeries and other non-emergent procedures, imaging maybe, like many of the things that hospitals make money doing they're restricted. And I can imagine the financial situation, particularly in rural hospitals, could get quite dire. The issue of transporting patients is interesting as well. I'm wondering who pays for that. And Gila Regional, our county hospital down here in Grant County, it came close to not being able to make payroll in May. Is there a component to the crisis level standards of care that helps or provides an injection of cash into hospitals to keep them afloat? Or is there a state level or federal resource component that will help hospitals pay their bills? Thanks.
That's a great question. Let me take us back to April, May, and what happened then. I think the state reacted and closed any kind of what we at the time called elective surgery, and we've all taken an oath never to use that word again, so I kind of violated it. But when we think of elective surgery, it's something like, well, maybe I could have it, or maybe I could do it next year, no big deal. The real term is I forgot the new term. Maybe one of you can help me out, but it's sort of medically necessary and non-medically necessary. So, if you have a breast tumor that might be cancerous, then maybe someone would call that elective because it's not an emergency. But the fact is you really need to have that biopsied. So when all that was closed, hospitals did run into very significant financial duress. And what we found was that the federal government provided, I think it was something like $170 million to providers in the state. The state Medicaid program provided $60 to $70 million to providers in the state to make up for that. I think this time the way we're thinking about it is the hospitals can make these adjustments on their own, that our main focus is on acute care facilities who have to move, literally change operating rooms over to ICUs. And so there aren't currently restrictions other than just what people are imposing on themselves in hospitals for volume. I think as we get to crisis standards of care, it's going to be necessary for the acute care hospitals to cut back on, surgeries in acute care settings, but almost all of them are already doing that fairly substantially. And then remember, if a hospital is 120% full, which they are now, as opposed to back in March and April, that's 20% more revenue. So we're watching that closely. We've had those discussions as the person responsible for Medicaid. We've been watching out for that as well. We did also boost provider payments. That was the $65 million back then. So we're watching that closely, something that bears watching. And I think your point that rural hospitals might be more vulnerable because they make a greater percent of their operating margin off of outpatient or ambulatory surgeries or procedures. I mean, that is an accurate statement. And that's something we watch. We're really paying attention to this time through.
Thank you, David. We have two more questions. First, I'm going to go to Nancy Laughlin with KOAT, and finally, Dan McKay from the Albuquerque Journal. Nancy, go ahead and ask your question.
Hi there. I just wanted to double check and make sure would you say that we're approaching crisis mode or that we're already in it? And my next question is, what is the bottom line? If you could get just in a brief synopsis, a bottom line that you want to tell our viewers about this.
Yeah, I think that the MAT has made a recommendation to DOH to make a formal declaration statewide. Clearly, there are hospitals out there that are experiencing extremely high demands that would categorize as that part of crisis care before the actual triage has to occur. And so I think from a very, very official point of view, we'll be in crisis standards of care statewide when the DOH declares that. And as I mentioned earlier, they're working on it. I think the bottom line for viewers, and I know everyone is looking for something more sophisticated than this, but it really is about wearing masks and keeping your hands clean and avoiding large gatherings and staying at home. And, if you're at high risk, really staying at home and finding ways to get other people to help you get the things you need. Even mixing, having your family all get together, 6 people, two each from 3 different households right now is dangerous. And so I guess my message to the public, and I'm going to ask Michael and Denise for their take on it as well, is now more than ever, do those things that we all know make a difference to our state, make a difference for keeping case counts down, and actually protect you personally and your family and your community. Denise.
Yeah, I think for the bottom line that I'd like to share from the delivery system, or those of us who are practicing in healthcare, is that you should feel reassured that we as physicians and providers in this state are going to step up, and we're going to do everything possible to take great care of you and to not limit any care. But that we do need the community's help. We need for the community to do all those things that we've talked about all along, so that we can continue to care for you and not to ever have to ration care.
Dr. Richards.
I think that those are really good points. We will continue to build as much capacity care as we can, and but I think that that the recognition that in aggregate that we've used up our the majority of our hospital capacity and our contingency capacity, and that we have to take these next set of measures very seriously, because we have to reduce the demand on the delivery system. We will find ourselves as a state in that place where we will have to make decisions about specific therapies and interventions, or where individuals will find that they're going to get transferred across New Mexico, a very big state, to get care because it's not available in their local community. And I agree with Dr. Gonzales. The delivery system has really stepped up and built lots of extra capacity, but that's not finite. And we need to be very thoughtful and careful to not get past what we're able to deliver in terms of our care for all of these patients.
Thank you, everyone. Finally, I'm going to turn over to Dan McKay from the Albuquerque Journal. Go ahead, Dan.
Hi, thank you for taking my question. Have New Mexico hospitals ever had to invoke these crisis standards of care and ration care the way you're talking about? Or is this unprecedented?
I'm going to go directly to Dr. Richards and then Dr. Gonzales on this one.
So this public health emergency is unprecedented. And what's different about this is that in other kinds of disaster circumstances, a particular community, a geographically isolated area may have an event, and it's oftentimes of a shorter duration, and the surrounding communities have resources that are available. And so we're able to move patients, even, over very large distances and other kinds of disasters. And that now, while there may be some short-term crisis-like care that might be provided, it's usually in that immediate phase, and then other resources are available. We send resources there, and we send patients to places that have capacity. That's not this event. This event is a worldwide public health emergency. And we're right now at a stage of this where it's impacting the entire United States. And so there really aren't places that have lots of excess capacity where we can send patients to. Or the biggest rate limiting step that we have right now at this in the response is really people. And so there aren't extra people to bring into New Mexico to create more capacity. Early on, maybe it was personal protective equipment, but we've got supply chain solutions for that now. So now it's people. And so no, we've never had an event like this of this duration in New Mexico or even the United States.
Yeah, I agree. It was very localized during the swine flu when we had our H1N1 response, and it was very limited. This has been protracted, prolonged, and worldwide. So yes, it's unique. It's unprecedented.
Yeah, and Dan, I think it's a great question. I would say it's unprecedented in the last 100 years. I'm sort of a student of the Spanish flu, which is the great influenza of 1918, 1919. You can kind of Google like a US news article that says poorly prepared New Mexico suffered greatly in the 1918 pandemic. Obviously, hospitals weren't as sophisticated back then. It seems like state health officials struggled to try to pull things together. But I do think it gives me a great opportunity, since this is the last question, to just end by going back to something that's been emphasized by Drs. Richards and Gonzales quite a bit, saying that's the partnership that the state has with our delivery system. We really have worked very much hand in hand, day after day after day, since the beginning of the pandemic, to plan this, to coordinate activities, to have the state do those things that the state can do, and the hospitals do those things that the hospitals are effective at doing. And I think that planning is paid off. You can Google a lot of press conferences of other states' governors bemoaning the fact that people just aren't working together. They're not pulling together. I think it was Cuomo said, I didn't realize that hospitals didn't really talk to each other that much. And so partly because we have less hospital beds, and partly because New Mexico is the kind of place where you can pull a relatively small number of people together, at least in healthcare, to make a huge difference for everyone in New Mexico. And I feel very, very privileged to be involved in this and to be able to be working with Dr. Gonzales, Dr. Richards, and the other Dr. Gonzales of Christus St. Vincent, and Clay Holderman, and Vesta Sandoval, and all of the other people, not to mention the state folks like Chris Emery and others, Laura Banks, who's the leader of our MAT team right now. It's been a great effort, and I think we're as ready as we can possibly be, because everybody's been working together so long. So stay safe, New Mexico. Please do those things. Understand that the point we're at right now involves the interaction between the people of New Mexico and the delivery system of New Mexico and the state government. And we just want you to be safe. We want all those hospital workers, some of them real heroes that have worked harder than they've ever worked in their whole life every day for 9 months straight. We want them to stay safe as well. And so please do everything to keep yourself safe, your family safe, your community safe, and please spread that word. And I think, Alex, with that, I'll turn it back to you if there are any last comments you have. Otherwise, we will be back for a regular press conference with the governor sometime soon.
That's right, David. The only other thing I'll add is that the recording for this press update will be posted on HSD's YouTube page, and you should receive a communication from our communications team about exactly where that is later today. So thank you, everyone, and thank you again for your patience.
Thank you. Bye-bye.